Hello and welcome to our group presentation. Today, our topic of interest is bipolar disorder. Our group consists of 6 members: Amutha, Kushi, Marianne, Ramisa, Sarah, and finally, myself, Tracy. So for this presentation, we're going to start by describing bipolar disorder and explain its significance. Next, we're going to list some of the characteristics and symptoms of the illness, following by the causes of the disease, whether they're genetic, neurochemical, or environmental. To continue, we're going to touch on the diagnosis of bipolar disorder, describing the tools necessary for the diagnosis, and the overlaps with other mental conditions. Afterwards, we will describe and analyze the different psychotherapies in use for bipolar disorder, and we will provide evidences of the effectiveness of the treatment for the disease management. In addition, we're going to describe an example of a case portraying the illness with an emphasis on the influence of the stigma around bipolar disorder. And lastly, we're going to finish off with a concluding statement.
Background. Bipolar disorder, formerly known as manic depression, is a mental illness that causes unusual shifts in an individual's mood, activity levels, energy, and concentration. The bi in bipolar describes the dualistic nature of these mood swings, ranging from extreme highs, known as manic episodes, to extreme lows, known as depressive episodes. These swings can last for days, weeks, or even months. Some may relate this to a roller coaster ride that never ends. Unfortunately, mania often triggers unwise actions linked to false beliefs such as overspending, risky sexual encounters, substance abuse, and other reckless behaviors. Subsequent depressive episodes plunge individuals into feelings of worthlessness and hopelessness, which is an excruciatingly painful experience. Thus, the mood swings associated with bipolar disorder significantly disrupt relationships, work, social life, and in severe cases may lead individuals into legal trouble. There are 3 main types of bipolar disorder: bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. Later in this presentation, we'll delve into the criteria for each type. Across all 3, individuals experience clear changes in mood, activity levels, and energy. These shifts can vary from intense periods of manic episodes and depressive episodes, and can even include milder manic episodes known as hypomanic episodes. Bipolar disorder is typically diagnosed in late adolescence or early adulthood, although symptoms may appear in childhood. The average age of onset for bipolar disorder is 25 years old, although the illness can start in early childhood or as late as 40s and 50s. While symptom presentation can fluctuate, managing bipolar disorder typically involves lifelong treatment. Adhering to a prescribed treatment plan can assist individuals in symptom management and enhancing their overall quality of life. Now let's take a look at some statistics regarding bipolar disorder. Globally, approximately 46 million individuals are affected by bipolar disorder. In Canada, 2.1% of individuals aged 15 and over experience symptoms meeting bipolar disorder criteria. Around 1 in 50 adults between the age ranges of 24 to 44 or 45 to 64 reported lifetime symptoms. The overall prevalence of bipolar disorder is roughly the same in men and women. However, women tend to experience depressive episodes, mixed mania, and rapid cycling more frequently than men. Among mood disorders, those diagnosed with bipolar disorder have the highest likelihood, 82.9%, of experiencing severe impairment. This impairment can affect daily activities, relationships, work, or school performance, and overall quality of life. Now let's consider the broader health implications of bipolar disorder. On average, bipolar disorder reduces the expected lifespan by 9.2 years. Individuals with bipolar disorder face a heightened risk of suicide, with 15 to 17% committing suicide. Up to 60% of individuals with bipolar disorder develop substance use disorders. Many individuals with bipolar disorder report co-occurring health conditions, including migraine, asthma, high cholesterol, high blood pressure, thyroid disease, and osteoarthritis. As we reflect on these statistics and health implications, It's crucial to remember that bipolar disorder is a lived reality for countless individuals who deserve our empathy and assistance. Understanding the prevalence and impact of bipolar disorder is not merely an academic exercise, it compels us to recognize the need for greater awareness and support systems to aid those affected by this complex condition.
So, what are some symptoms of bipolar disorder according to the DSM 5 by the American Psychiatric Association? Generally, bipolar disorder is marked by episodes of mania or hypomania and depression. Manic, hypomanic, and major depressive episodes characterize each of the three types of bipolar disorders differently, but before discussing these characterizations, let's first define the presenting symptoms found in each episode. According to the American Psychiatric Association, in the DSM 5, a manic episode can be defined as a period of elevated, expansive, or irritable mood that persists for most of the day, nearly every day for a week, or less than a week if hospitalized. So, during a manic episode, an individual feels increased activity, euphoria, and excessive joy, and they feel like they are on top of the world. Mania is also accompanied by at least three additional symptoms, which can be any of the following: increased self esteem or grandiosity, decreased need for sleep, meaning the individual sleeps less or wakes up way earlier than usual but does not feel tired and instead feels rested and energetic, feeling the need to continuously talk without regard for the other person, having a flight of ideas, meaning the individual is having multiple thoughts running faster than their speech can catch up to, distractibility to irrelevant external stimuli, increased goal-directed activity, and excessive participation in pleasurable activities that can have a potential for unpleasant consequences. Notably, in accordance with DSM-5 criteria, these symptoms should cause impairment in social or occupational functioning and should not be caused by any other medical condition or exogenous substance. In comparison to a manic episode, a hypomanic episode has the same key and additional symptoms, but the only differences are that these symptoms last for at least 4 days instead of a week, the episode is not severe enough to cause dysfunction or need hospitalization, and the episode does not involve psychosis. Conversely, a major depressive episode is characterized by either depressed mood or anhedonia, which is a loss of interest or pleasure in all or almost all activities of life, as well as 5 or more additional symptoms, which can include changes in appetite, significant weight gain or loss not attributable to dieting, sleep loss caused by insomnia or hypersomnia, psychomotor slowing, feelings of worthlessness or unnecessary guilt, changes in cognition such as decreased concentration or inability to make decisions, and recurrent suicidal ideation, thoughts of death, or even an attempt at suicide. So, during a major depressive episode, an individual is in a really low, sad state where they do not see themselves as on top of the world like they do during mania, but instead the world seems dark, challenging, and overwhelming. Notably, these key and additional symptoms must be present nearly every day for at least 2 weeks, cause dysfunction in important areas of functioning, and must not be caused by another medical condition or exogenous substance to be considered part of a major depressive episode. Now that we have looked at the symptoms of bipolar disorder generally, it is important to note how these symptoms characterize each of the three types of bipolar disorders, which are bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. According to the American Psychiatric Association, bipolar 1 disorder requires a criteria for at least one manic episode to be met, so an individual must feel elevated, expansive, or irritable mood almost every day for a week, in addition to 3 of the other manic symptoms previously noted. In contrast, bipolar 2 disorder requires the criteria for at least one hypomanic episode and one major depressive episode to be met, with no manic episodes occurring. So, an individual may feel a period of elevated, expansive, or irritable mood almost every day for at least 4 days, in addition to 3 hypomanic symptoms, as well as a period of depressed mood or anhedonia almost every day for at least 2 weeks, in addition to 5 other depressive symptoms. Lastly, cyclothymic disorder is when an individual experiences chronic symptoms of hypomania or depression for at least 2 years, with no more than 2 month breaks between symptoms, but the individual does not experience enough symptoms, severity of symptoms, or duration of symptoms to be classified as having full hypomanic, manic, or major depressive episodes.
Causes. The exact cause of bipolar disorder is still unknown, but it is believed to result from a combination of genetic, neurochemical, and environmental factors. Studies suggest that imbalances in neurotransmitters, particularly dopamine and serotonin, as well as intracellular signaling systems that regulate mood, all contribute to the development of bipolar disorder. Although the exact cause is not yet identified, research indicates that there are several risk factors associated with the development of this mental disorder. First, I'm going to discuss genetic factors that increase someone's risk of developing bipolar disorder. Numerous genetic loci on chromosome 11 have been shown to contribute to bipolar disorder. These loci describe the actual location of the gene on a region of a chromosome. So over 30 different genes have since been associated with increased bipolar disorder risk. That was found by Jane and Mitra 2023. Certain genetic variations inherited from parents can increase the probability of developing bipolar disorder. These genetic predispositions can affect neurotransmitter levels, which impact how the brain responds to stress, as well as to other environmental factors. Additionally, twin studies, particularly those involving monozygotic twins, who share identical genetic makeup, have shown that the likelihood of both twins developing bipolar disorder is between 40 and 70% if one twin already has the disorder. First-degree relatives, also known as your immediate family members, face a lifetime risk of developing bipolar disorder of around 5 to 10%, which is substantially higher than the general population risk, which falls around 1%. There are also many environmental factors that increase bipolar disorder risk. Childhood maltreatment, particularly emotional abuse or neglect, is correlated with later development of bipolar disorder. Chronic stress and trauma can adversely affect brain structure and function, including impairments in regions involved in emotional regulation and stress response, such as the amygdala and prefrontal cortex. These structural changes may disrupt normal brain processes and increase susceptibility to mood dysregulation and psychiatric disorders, including bipolar disorder. Experiencing periods of high stress, such as traumatic events, can also contribute to the risk of bipolar disorder. In adulthood, over 60% of bipolar disorder patients report a significant stressful event preceding manic or depressive episodes. This can include childbirth, divorce, or unemployment. In these stressful events can lead to significant psychosocial challenges and disruptions in social support networks. These social support networks play a crucial role in buffering against the negative effects of stress and promoting well-being. A lack of adequate social support can worsen stress and increase the risk of developing or even worsening symptoms of bipolar disorder. Drug or alcohol abuse is another environmental risk factor for bipolar disorder. Antidepressant use in depressed youth may also induce manic symptoms. Antidepressants are commonly prescribed for individuals with depression, including those who may have undiagnosed bipolar disorder. In some cases, the use of antidepressants in individuals with undiagnosed bipolar disorder can trigger manic or hypomanic episodes, leading to a switch from depression to mania or hypomania. Substance misuse intensifies illness prognosis as well. Additionally, smoking correlates with an increased risk of psychiatric disorders, including bipolar disorder. Maternal smoking during pregnancy poses a concern for offspring, as exposure to tobacco smoke in utero may adversely affect fetal brain development and increase the risk of psychiatric disorders later in life. Viral infections have also been associated with bipolar disorder. Rowland and Marwa found strong evidence linking positivity for a T. gondii infection with bipolar disorder. T. gondii is a parasite that can infect humans through the ingestion of contaminated food or water, or through exposure to infected animals. Research suggests that T. gondii infections alter dopamine metabolism in the brain. Dopamine is a neurotransmitter associated with mood regulation, reward processing, and motor control. Dysregulation of dopamine metabolism may disrupt normal brain function and contribute to the development of psychiatric disorders, including bipolar disorder. The altered dopamine metabolism associated with T. gondii infections may potentially trigger manic episodes in individuals predisposed to bipolar disorder. Furthermore, T. gondii infections can lead to alterations in cytokine levels in the body. Cytokines are signaling molecules involved in the immune response and in inflammation. Dysregulation of cytokine levels, particularly interleukin 6, has been implicated in mental illnesses, including bipolar disorder.
Now we are going to discuss the diagnosis of bipolar disorder. Bipolar disorder has to be diagnosed by a healthcare professional in order to receive the right treatments. The tools that might be used are a physical exam, 1, 2, a thorough medical history, which will include asking about the symptoms, lifetime history, family history, and the person's experiences as well. 3, medical testing, such as blood tests to rule out other conditions that could be causing the symptoms, such as hyperthyroidism, because hyperthyroidism can cause symptoms such as restlessness, irritability, anxiety, panic attacks, and signs of mania. And last, mental health evaluation. So the healthcare professional may perform an evaluation, or they may refer the person to a mental health specialist, such as a psychologist or a psychiatrist. So a diagnosis of bipolar disorder requires the presence of at least one episode of mania or hypomania. Mental health professionals rely now on the DSM-5 to determine the specific type of bipolar disorder the a person may have, and they will also evaluate the pattern and severity of the symptom during the most severe episodes to ascertain which type of bipolar disorder it is. A lot of people diagnosed with bipolar disorder might have other comorbidities alongside, such as eating disorders, anxiety disorders, attention deficit hyperactivity disorder or ADHD, drug or alcohol misuse, or post-traumatic stress disorder or PTSD. So because of other conditions or overlapping symptoms, people with bipolar disorder who are experiencing a severe manic episode with hallucinations may be incorrectly diagnosed with schizophrenia and sometimes misdiagnosed as borderline personality disorder or BPD. So it can be difficult for a healthcare provider to properly diagnose people with bipolar disorder. And therefore, honesty is crucial when explaining all the symptoms and experiences to a healthcare provider. It can be helpful as well to include a loved one who may be able to provide additional details about the person's mental health history in their discussions with the healthcare specialists.
Non-medication therapies. Psychotherapy is often used as treatment for bipolar disorder. The first one is cognitive behavioral therapy, also called CBT. CBT sessions are done with a cognitive behavioral therapist in one-on-one sessions or in group sessions with people in similar situations. It combines cognitive and behavioral therapy. We know that healthy thoughts lead to healthy feelings and behavior. So in CBT, patients record and monitor their thoughts and identify what triggers their bipolar episodes. They are then given strategies to address their triggers and replace their negative behaviors and beliefs with positive ones. Next, we have psychoeducation. Psychoeducation is performed by a psychologist, and it focuses on teaching the patients about bipolar disorder in greater detail so that they can work with mental health professionals to improve their health outcomes. Psychoeducation combines cognitive behavioral therapy, group therapy, and education. Psychoeducation can be provided just to the patient, or it can be provided to the patient and their family as well. Next, we have interpersonal and social rhythm therapy, also called IPSRT. This treatment is provided by a trained psychiatrist, and it focuses on the four main areas of interpersonal psychotherapy. The first one is grief. Second, we have role of transition, which means a major life change such as retirement, birth of their child, etc. Third, we have role of disputes, which is a conflict in an important relationship such as with their parents, spouse, boss, etc. Fourth, we have interpersonal deficits, which means that the person goes into social isolation and lacks interpersonal connection and support. These four areas of interpersonal psychotherapy are combined with strategies to improve the social and circadian rhythms in IPSRT, and this in turn helps improve the patient's mood. IPSRT also provides patients with skills to protect themselves from future episodes related to bipolar disorder. Next, we have family-focused therapy. Family-focused therapy not only includes psychoeducation, but it also includes family-oriented psychotherapy. In FFT, the whole family is treated together along with the patient, which means all of them are included in the therapy sessions. And they work towards improving their communication styles, developing healthier relationships, and developing effective plans to tackle bipolar disorder related challenges. Family focused therapy helps the families understand their role in the healing process of the family member that does have bipolar disorder. And it is different from psychoeducation because psychoeducation focuses on educating individuals and families, whereas family focused therapy focuses on improving the relationships and the dynamic between the family members. Lastly, we have electroconvulsive therapy, also called ECT, which is commonly used in patients that have not responded to other treatments. And it is typically administered by a team of medical professionals that includes a psychiatrist, anesthesiologist, and a nurse or physician assistant. In electroconvulsive therapy, the patient's brain is given brief electrical stimulation while they are under anesthesia, and it is effective for the treatment of episodes related to bipolar disorder. But it is important to note that electroconvulsive therapy does not prevent the return of bipolar related symptoms in the future. Hence, the five therapies that we have discussed are used for effective treatment and management of bipolar disorder.
Media portrayal. We will be looking at the show Shameless, specifically the character Ian Gallagher. Ian Gallagher was diagnosed with bipolar disorder in his late teens. After coming home from the military, his family notices that he has changed a lot. We see him go through several manic episodes followed by depressive episodes. During his highs, he would be very restless and hyperactive, and we would see him awake in the middle of the night cooking so enthusiastically. But then during his lows, he would be in a depressive mood, there was a loss of interest, and he could not get up from his bed for days at a time. Furthermore, Ian used drugs to cope with his mood swings. But the most important part of all of this is that he was in denial of his diagnosis. He did not want to get help, he didn't think that he needed help, and in one of his quotes, he did not want to go to a nut house. By the end of the show, we see him come to terms with his diagnosis, practice self care, and start taking his medications. Expanding on the character Ian Gallagher, he was a very sympathetic and ambitious person, was not violent or explosive, and was well adjusted compared to his siblings. His job working as an emergency medical technician was a turning point for his diagnosis. This was a job he loved and felt a sense of purpose in. But unfortunately, he was quickly kicked off the team for not disclosing having bipolar disorder. And so, he confronted his supervisor, who had commended his abilities in the past, and explained to her that people with bipolar disorder can hold down jobs and be functional members of society. Down the road, he realizes that he is simply a young man who is struggling with a condition he does not know much about. Once he accepted his diagnosis, he took it upon himself to get the help he needed and learn more about how to live with bipolar disorder. Overall, the show Shameless, through the character Ian Gallagher, portrayed bipolar disorder positively and in a way that was realistic and dignified. But sadly, this is not how bipolar disorder is commonly portrayed in the media. Most of the time, people living with bipolar disorder are represented in the following ways: violent, disastrous, and unreliable. In the movie Silver Linings Playbook, Pat's manic episodes consist of him being violent. This type of portrayal causes fear and makes the public see people living with bipolar disorder as a danger to society. Up next, we have the show Law and Order. We are introduced to Jamie Hoskins, who has bipolar disorder but refuses to take her medications due to opposition to treatment for mental illness. And as a result, she falsely accuses a young man of rape and hits 8 people with her car, killing one of them. This betrayal pushes the belief that bipolar disorder leads to crime and that people living with it either do not take their medications or do not want to get better. This paints a skewed picture of bipolar disorder since it is estimated that 50% of patients, this includes all health conditions, do not take their medications as prescribed. So noncompliance is seen across all illnesses. Finally, we have unreliability as seen in the show Ozarks. The character Ben has mood swings that change in an instant. His reactions are very dramatic, including throwing his student's phone into a wood chipper and physically assaulting a worker. In addition, he is constantly putting his family through stressful situations to the point where they get a hitman to kill him. Ozark tries to portray unreliability and unpredictability as associated with bipolar disorder. But in all of these examples, bipolar disorder is not accurately depicted and focuses on negative extremes. Unless the media shifts away from negative portrayals of bipolar disorder, public attitudes regarding this illness will remain mostly negative.
Now let's summarize all the information. In conclusion, bipolar disorder is a complex lifelong illness characterized by mood swings that necessitate proper management in order for the patients to achieve a better quality of life. The presentation highlighted the causes and symptoms of the illness, as well as its diagnosis, all of them in regards to the DSM-5 criteria. We decided to focus on the different types of psychotherapies existing for bipolar disorder for the treatments, such as cognitive behavioral therapy being the most effective one, but also family-focused therapy, or even interpersonal and social rhythm therapy, for example. Lastly, through the character of Ian Gallagher on the show Shameless, we were able to show the reality of an individual living with bipolar disorder, not just from a medical point of view, but also from a social point of view. Moreover, we can now understand the challenges faced by the patients with the illness. Through our exploration, we hope to have raised awareness and deepen your understanding on the condition. Thank you for your attention.